so if you look up the internet, you find that, yes, minimally invasive means surgical procedures with the least possible trauma, or you can also call it keyhole surgery, which just simplifies this term. And I think there are a lot of techniques that you can judge as minimally invasive. For instance, neuroendoscopy, that also accounts for image-guided microsurgery by use of navigation systems, frameless stereotaxy, like here robotic-assisted systems. But sure, also for frame-based taxi, and that's what's my daily job and what I will talk about here in the next couple of minutes. So let's start with a look back into the past. The first stereotactic frame. Everything okay? Okay. The first stereotactic frame was established in the beginning of the 20th century by Horsley and Clark. They use it to access deep brain-seated regions by brain maps. And yeah, still frames also from the 15th of the 20th century are still used in also modern stereotaxy. Now, that's what we can do with a frame like that. We can do oncological treatments, but also functional stereotaxy like deep brain stimulation, or also radiosurgery, which is sometimes also frame-based possible. So I will talk about in the next slides about oncological stereotaxy, mainly biopsy, puncture, shunts, and also I will show you stereotactic brachytherapy, which I think not everybody is familiar with. So the frame-based stereotactic approach means, and I will show you the procedure in some steps, that you have the head fixations. You already know this image. And after that, we do a CT scan and we match the CT images with pre-surgery obtained, for instance, MRI images. And so we translate the image coordinates from the CT into the image coordinates from the MRI and vice versa. And then we can do a treatment planning and decide where's our region of interest. So in this example here in the mesencephalon, then we can plan a trajectory, and then it follows our keyhole surgery or minimally invasive surgery. And yeah, it can result in therapy or also in a biopsy and punctures of other processes. So on this small cylinder that we, tissue cylinder that we get, you can do all of the research which is necessary, or examinations, better say that, that you need in modern neuropathology, like morphologically examinations, but also immunohistochemistry or molecular biology, which is the important thing nowadays. So, but we ask ourselves, how is it about this diagnostic? The diagnostic yield is mainly essential for a biopsy because we only have this small specimen. And so we did a literature research about the, yeah, I would say last 30 years or nearly 40 years, with yeah, nearly 9,000 biopsies involved. And you see there's a wide range of diagnostic yield. There's also a wide range concerning the risk profile. But sure, there are studies from the late 80s, from the 90s, and yeah, you can judge them as kind of historical studies. And yeah, why do we have this wide range here? The reason for that is the imaging, I think, because you can only be as precise as the images are. We did not have this thin sliced images, CT images, and also MRI images in the 80s and 90s. And also we did not had metabolic imaging as we have it today. And you see here in this example, if you imagine the MRI or T1, that you have to decide where to take the biopsy here, it's kind of difficult. But if you have the amino acid PET, it would be more easy just to decide where is my region of interest and where should I take the biopsy. I think that improves our results. And if we see in the more modern series, they are also from our department here, you see, for example, when you see this analysis of midline lesions, that we have a very high diagnostic yield and a very low risk profile compared to this, more or less historical studies. So, but there are also other things we can do with frame-based procedures. Another thing I want to show you here. Here is a patient with a cyst in the mesencephalon after irradiation from pilocytic astrocytoma. So how to access this minimally invasive is really not so easy, but if you have a stereotactic procedure, is it possible to implant catheter here, pinpoint in the fourth ventricle and make a connection then between the cyst and the ventricle. And that's how, as you see in this example, the cyst resolve 6 months after. So did an analysis of a small cohort of patients, and we see recurrence-free survival after 6 months of 93 and after 3 years of 87% with a very low complication rate. So keep that in mind. It's also a minimally invasive strategy to treat intracerebral or acquired cysts. So I summarize here, there are indications for stereotactic procedures. I see them mainly in specimen extraction, that we can get a diagnosis for unclear processes, intracerebral processes, but also we can evacuate cysts or abscesses, and also here the diagnosis in terms of abscesses are also necessary. Okay, there will also be something about brachytherapy, and this is a frame-based stereotactic irradiation. It's a very special a treatment, and I think not every institution has the possibility to do that. I think there are only some institutions in Germany left. I don't know if there are some in Greek. First of all, you should know that there are different techniques of radiation. So if you see a tumor like that, it's a metastasis, sure, you can do surgery, but later on you will need to do irradiation. So if you think about irradiation, there are different types. The classical one, I would say, is a fractionated radiotherapy, where you apply between 50 to 60 gray in a couple of weeks, or better say it's in daily fractions during these weeks. Then we have, in contrast to that, stereotactic radiosurgery. Here you give the radiation dose in a couple of hours. But in stereotactic brachytherapy, you do the radiation from the inside of the tumor. So you implant the radiation source inside the tumor, and you irradiate a tumor, in months. So nearly could be also 1 year. So that's the difference between these types of radiation. So we have to get the radiation sources inside the tumor, and that is the minimally surgical approach we have here. So you remember, as I showed you, this procedure, it's nearly the same, but when we come to treatment planning, there's something is different. And I have an example here for you of an osteocytoma WHO2, where we want to irradiate it with 50 gray. That's a typical dose. So during the treatment planning, we have to outline the tumor surface, and that's the blue dotted line here. I hope you can see the arrow here. And the radiation dose is the green line, which sends the tumor surface, and that are the 50 gray that we want to implant in the tumor. And we do that by 2 catheters. In this case, here you see a green catheter and a red catheter, which is filled with small black particles. These are iodine seeds, radioactive iodine, which do the radiation, and our physicists calculate how how strength these iodine seeds must be that we achieve after 1 year the desired radiation dose here. And in the inside of the tumor, we have a much higher radiation dose. You see it here in this example with the orange line, which resulted in finally 200 gray. So, okay, now the procedure, the workaround can go on. We have the treatment planning. Then here we implant the catheter. Here you see that, and it will be then mounted to the bone, and it results in the brachytherapy for the patient. Here, an example of iodine seed, nearly the size of a match head. So, okay. Follow this case now, where we implant these 2 catheters. Here you see the catheter. This was the tumor pre-surgery, then 3 months later. And then we see a reaction after 12 months. And sometimes, don't have it always, but it's 10 up to 20% possible that we have this reaction with also contrast enhancement. And some radiologists may judge that as a tumor progression or malignization, whatever. But it's kind of a not the desired radiation effect, but kind of an adverse effect. And normally, if you just wait a bit, it will resolve. And as you see in this example, then nearly 3 years after, the tumor is in nearly complete remission. So there are also guideline relevant literature for this treatment, especially for children, because in pediatric tumors, it's often difficult to do radiation because of the development of the brain can harm a brain tissue, and with brachytherapy we are able to preserve brain tissue for alterations. And that's why it's here in the guideline for pediatric tumors, also a recommendation to do brachytherapy in some kinds of tumors, especially in WHO grade 1 and 2. And here in our series, it was nearly 150 patients where we have only a very small transient morbidity, and in most of the patients, the neurological state improved after implantation of the iodine seeds. And if you see the progression-free survival, then after 5 years with 92%, it is considerable results. There was not a difference between WH grade 1 or 2. And so this is still a part of the current recommendations for treating gliomas in children. So I summarize here the stereotactic brachytherapy. In the end, it's suitable for nearly every circumscribed intrinsic tumors. The procedural risk is low. We can improve symptoms, and you can also combine it with biopsy, microsurgery, if there are, for example, remnants which cannot be resected. Or it can also be combined with percutaneous radiation. So that's the end of my talk, and thank you for your attention. And now you can pose your questions if there are any.
Thank you, Dr. Ruess. Thank you for being with us. Very nice talk, of course, and something new that you brought up, this stereotactic brachytherapy. Very nice cases you show us. If there are any questions from the audience or comments, I would like to ask you if there are any side effects or complications from the brachytherapy, and which patients benefits you think that there benefit from brachytherapy. Brachytherapy is a new tool coming from the past, yes, because we had this brachytherapy in the early 90s, and then it was abandoned. Let me see what are the new trends of the brachytherapy, the side effects, the patients are there benefit. What kind of complications do you expect from the brachytherapy? Or do you have?
The complications we have are mostly adverse effects, which shown up after 3 to 6 months, sometimes also after 12 months. And they're coming from the radiation, but they also disappear then again. So that there's a permanent morbidity that is very rare. So most of the patients resolved after the treatment, but sure, that is a problem that we have that after a certain time, and you can't calculate that before. So you don't know if this patient will have adverse effect or not. So.
I see. So, and do you have any edema formation after brachytherapy, or because it's controlled, it's much less? Because this was the problem with the brachytherapy in the past.
Yeah, it depends. You have in some patients you have it, in some not. Even if you think of more tumors like metastasis, where we have much higher dose. Interestingly, in these patients we have less edema. I think it's because the tumor shrinks faster. You saw this example of the astrocytoma. It is a very big tumor and it does not shrink so fast. And then if it comes the adverse reaction on top, then you will have an edema and you will also have a symptomatic edema. That's always the problem with radiation. If you have the tumor inside, there's also volume inside. So that's not a decompensate state will come then, or will show up very fast. So that's a problem with that. But all in all, some patients need corticosteroid treatment, but that can also resolve after that.
Yeah. So, in which patient would you recommend to do brachytherapy? In a patient with glioma, in a patient with metastasis, in an old patient, a young patient?
What I would recommend are the children, as I show you in the last example. That's also guideline relevant. And patients which already had radiation and surgery before, where it is possible to do not possible to do another surgery, or where it's possible to do radiation, because maybe because of the surrounding tissue, for example. So if we do the radiation from the inside the tumor, so that is a gap that we can fill with this brachytherapy, where the radiologists say, oh, I can't do radiation, there's too much dose on the, I don't know, on the optic system, for example, then we can do the brachytherapy.
I see. You said children, and I saw that you have written 2 or 3 papers within pediatric research. In which age do you recommend pediatric treatment with brachytherapy? Up to 6 years, for example?
6 years of the patient? Oh no, also older patients. Up to it
No,
can
I mean,
also go in the age of the young adults, so the adolescent. It's not, there's not a strict line where I would say it's in 18 years now it's over. So in the series I show you, it was up to 20 years. The oldest patient was nearly 20 years.
Mm-hmm. Do you think that the benefit it's more on metastasis or on gliomas?
There's more on the gliomas, because for the metastasis there are so many different treatments, and in most cases it's necessary to either resect a tumor, or you can have alternatives like radiosurgery or fractionated radiation therapy, where it doesn't make so much benefit to do brachytherapy. So if you want to do a surgery for metastasis, better resect it.
So better for gliomas. You didn't try it in glioblastomas, or?
Yes, sure.
You did.
We tried in glioblastomas. The results were, yeah, I would say a bit indifferent, but we don't have, yeah, such studies where we just can compare it, yeah, like a controlled clinical trial. And the problem is in glioblastoma, I showed you that we have to define the target volume. And I showed you that there is a radiation dose which would cover the tumor surface. But the radiation comes from the inside. It takes a while until the desired dose, reach the surface of the tumor. And in this time, could be some weeks, maybe the tumor grows faster from the outside, and we cannot reach it from the inside where the radiation source is. Yeah, it takes a while until it's a kind of a summary. Yeah, the radiation dose which we achieve, for example, with this case I showed you of astrocytoma, we reach 50 gray after 1 year. So in slow-growing tumor, that's a perfect idea. But in fast-growing tumors, it could be a problem that the time until all the radiation is inside the tumor already grows from the outside.
So
it grows away, yeah?
Yeah. Okay, you didn't try it in diffuse gliomas, or? For
The
example.
problem with, yeah, it depends. The problem with I don't know what you mean with diffuse gliomas in this circumstance, because if you mean diffuse, we can only implant it in tumors which are circumscribed, where we see the border of the tumor. If we don't see a border of the tumor, this treatment is not suitable.
Okay. Robert, do you have any comments to do with?
Yeah, I would like to comment that we are very
Yes, of course.
happy that we have Dr. Ruess and his team in our center. Especially in low grades, we are often doing a combined approach. If it's very large frontotemporal insular low grade, we can, with low risk, resect the frontal part. We can resect with very low risk the temporal part. But if you go into the insular, the risk is increasing dramatically. So these parts usually are implanted by Dr. Ruess, and then we have a complete treatment of tumor volume, and the total risk for the patient is quite low. So this is why I personally like the brachytherapy a lot. And there are also, as Dr. Ruess has mentioned, some indication for metastasis. If patients are not willing to take some risk, or if we as neurosurgeons say the risk is so high, maybe it's better to do some brachytherapy in a very medially or in the located or a tumor in the basal ganglia or something like that.
So it's a very nice complementary therapy. Unfortunately, we don't have in Greece this kind of therapies. Actually, it's a new one. How many years you do brachytherapy in Köln?
It's from the beginning of the 90s.
From
the
the 90s.
Tradition here. Yeah.
I mean,
sure.
In the 90s, yeah.
Yeah, in the 90s. I think the first one was 93 or something, which was implanted here.
Okay, because we did also in Greece, but we abandoned it. The brachytherapy. Okay.
I don't know why.
Well, because of the complications, we just had to put. You remember this small tube? It was a lot of complications with infections, and we didn't see any much improvement. It was okay, considering a palliative therapy, but it's coming up. It's coming up. That's a very nice case that you show us, and promising.
I wonder, because I never. It's really true. I never observe an infection of so I wonder about that. Infection after we had infections after explantation of the catheter, but during brachytherapy, I've never observed that.
Yes. I had myself